Pneumonia is going to be such a common topic that you're going to see in exams. At the same time, you're going to encounter in your wards as well. So, what do you mean by pneumonia and what is the definition of pneumonia in the first place? If you take what do you mean by pneumonia, it is nothing but an infection of an alveoli or interstitium or both. That's all. That's pneumonia. If you have an infection of airways, that is different. For example, if you have an infection of the bronchus, that's called bronchitis and not a pneumonia. If you have an infection of the bronchus along with the air spaces, then you call it as a bronchopneumonia. So the terminology is like sometimes confusing, but they are very crystal clear in their own aspects. So first, let us see what is pneumonia. You have an alveoli, you have the capillaries, and you have the basement membrane. This is the blood barrier, and you have the interstitium organ. So pneumonia means you have infection either in the alveoli or in the interstitium or both, and this is what you're going to call as a pneumonia. So once you have learned what is a pneumonia, then see how can you classify the pneumonia. How can you classify the pneumonia? Classification wise, you can classify pneumonia based on three different things into different types. The first one is based on the pre-existing conditions that predispose to pneumonia. In this way, you can divide into a primary pneumonia or a secondary pneumonia. A primary pneumonia means there is no pre-existing condition that predispose to pneumonia. Secondary pneumonia means there is a pre-existing condition that actually predispose to the pneumonia. Like it could be a cardiac failure, it could be a lung disease like COPD and asthma, it could be a kidney disease, it could be aspiration, it could be a viral infection that subsequently predisposes to a bacterial pneumonia. That's a very important thing. Pre-existing viral infection, or if I get a viral infection now, in the next 1 or 2 weeks, I have a high risk of getting a bacterial pneumonia as a like part of this viral pneumonia super infection. So that is also possible. So, or it could be some congenital disorders or anatomical or function malformations like cystic fibrosis, Cartagener syndrome, bronchiectasis. So, a lot of things. If you have something that predisposed to the pneumonia underneath, then you call it a secondary pneumonia. So, there are two types. That's it. Second thing is based on the setting where you get a pneumonia. Based on the setting where you get a pneumonia, you can classify into a communicable pneumonia, the classic form, where the patient has not got admitted to the hospital recently. So in those settings, you can diagnose a community-acquired pneumonia. So then you have something called hospital-acquired pneumonia. I told you community-acquired pneumonia is a pneumonia that you get outside the hospital setting. So hospital-acquired pneumonia is something what you're going to get inside the hospital setting. Like the best definition for a hospital-acquired pneumonia is when you get a pneumonia after 48 hours of admission to the hospital. That's what we call the hospital-acquired pneumonia. Now your question will come, what if I get a pneumonia in the first 48 hours of hospital admission? So if you get a pneumonia in the first 48 hours of hospital admission, then it will be treated like a community-acquired pneumonia. So it will come under a community-acquired pneumonia only, it will not come under a hospital-acquired pneumonia. Then you have ventilator-associated pneumonia. What do you mean by ventilator-associated pneumonia? It is almost similar to hospital-acquired pneumonia, but it is like if you get a pneumonia after 48 hours of endotracheal intubation. Endotracheal intubation. Okay, so this is what we call it ventilator-associated pneumonia. Suppose if you get a pneumonia within the first 48 hours of endotracheal intubation, then it could be a hospital-acquired pneumonia if the patient was in the hospital for more than 48 hours, or it could be even a community-acquired pneumonia if the patient was intubated within the first 48 hours of hospital-acquired or hospital admission. So this could be something else. So, but remember, hospital-acquired pneumonia means patient getting a pneumonia after 48 hours of hospital admission, and ventilator-associated pneumonia means patient getting a pneumonia after 48 hours of ventilator or 48 hours of endotracheal intubation. Clear? But you had another term called healthcare associated pneumonia, called HCAP. But now this terminology was completely abandoned by many textbooks because it was actually merged with community-acquired pneumonia. So now we don't have a separate definition for community-acquired pneumonia, healthcare associated pneumonia, but instead it is merged along with the community-acquired pneumonia. But traditionally, let us see what are the risk factors of getting a healthcare associated pneumonia. Number one, if the patient had a hospital admission, but not recently, but very remotely, but within the last 90 days. Or if the patient had an antibiotic use in the last 90 days, any form of antibiotic. The patient had underwent a dialysis in the last 90 days, or any immunosuppressed patient like HIV, or patient who was receiving a chemotherapy or a cancer drug, patient who are living in nursing homes, patient who are receiving home infusions. Like sometimes we give antibiotics in home itself just to reduce the cost. So home infusions, patient who are receiving home infusions like antibiotics and any other infusions that are going on in the home. If some patients who are doing home wound care, very common is in the form of a diabetic foot, which might be treated a little bit in the hospital and later on we discharge them and go home and ask them to go home and dress themselves in the home. So this is called home wound care. And finally, a family member with MDR pathogen. They had already a family member who had an MDR pathogen. So these are the risk factors for developing a healthcare associated pneumonia. But now the terminology of healthcare pneumonia has been removed. So what are these things going to do now? Suppose if any of these factors are associated with the community acquired pneumonia, because that's what you have to call now, because you don't have the term called HCM. So all these things, if any of these factors, which were previously risk factors for healthcare associated pneumonia, now they are risk factors for MDR organism in a community acquired pneumonia. Okay? So which means all these things, whatever I told, are risk factors for healthcare associated pneumonia. Now it's just these are risk factors for community acquired pneumonia with an MDR organism. That's all. So we cannot use the term called healthcare associated pneumonia. In this, the first three must be the most important. Clear? Now the last but not the least, classification, that's typical versus atypical pneumonia. This is what a second year student is going to be absolutely familiar with, typical versus an atypical pneumonia. So how can you differentiate? It's a simple microbiology sort of a thing, typical versus a atypical pneumonia. First of all, onset is sudden for a typical pneumonia, whereas it will be very gradual in atypical pneumonia. Fever tends to be a high grade in case of typical pneumonia, where it tends to be very low grade in atypical pneumonia. At the same time, expectorations are very common and the sputum tends to be very productive and purulent in case of a typical pneumonia, and they can be associated with a little bit of streaks of blood many times. But atypical pneumonia, they will have a very scanty sputum. They will not have a productive sputum. Many of the atypical pneumonia patients will be suffering from dry cough often. At the same time, there are two qualities of the sputum that you have to know. One is called a rusty sputum, and second one, you have a red currant jelly sputum. Red currant jelly sputum. Rusty sputum generally is a classic hallmark of a pneumococcal pneumonia, and the red currant jelly sputum is generally a hallmark of a Klebsiella pneumonia, traditionally, Eureka link. So you have to know that. That's it. But apart from that, these and all will not tell you any clear-cut detail, that too in the current era. So just remember for the exam and namesake. That's all. Then, what will be the clinical features? How the clinical presentation of these patients? I told you the clinical presentation will be acute and sudden onset, cough, and productive cough. It will be productive in nature, and the patient might have shortness of breath, and very classically, many of them will have pleuritic pain, and they will have a spiking temperature, very high grade fever. So this is how most of the times, typical pneumonia will come. Atypical pneumonia will be a little bit acute to subacute. It will not be usually acute, it will be acute to subacute. Most of the times, initially, they will have a URA kind of a symptom. Then only they will go for a full-blown pneumonia-like picture, that is shortness of breath and dry cough. So pleuritic pain, this purulent sputum, all these things are very rare in atypical pneumonia. Similarly, you will get classic signs of consolidation in a typical pneumonia only. You have the typical signs of consolidation in a typical pneumonia only. All the typical signs of consolidation will be lost in a atypical pneumonia. Remember, what do you mean by typical signs of consolidation? Clinically, if you mean by typical signs of consolidation, the first one is the crack, the crepitation that you see. That's very, very common in typical pneumonia. And the second one, you can see this high-pitched bronchial breathing, which will be generally associated with increased vocal resonance, increased tactile vocal frequency, and you can have additional sounds like bronchophony, egophony, whispering pectoraloquy. All these things are associated with your typical pneumonia. It will not be associated with the atypical pneumonia in general. So why you get a bronchial breathing? Clear? And many of the times, remember, this bronchial breathing will correlate with the chest X-ray and radiology in the form of air bronchograms. Whenever you have an air bronchogram, that correlates with the bronchial breathing, and whenever you have bronchial breathing, but they will definitely correlate with air bronchograms in your imaging. Okay, so what is the relationship between this bronchial breathing and why don't you get a bronchial breathing in normal people, and what is air bronchogram? Let us see some of the basic ideas. So normally you have this larger alveolus. So let us take this as a bronchi. That's a larger alveolus. And surrounding this, because bronchus are in the central and surrounding you have a lot of lung parenchyma which is surrounded with alveoli. So let us assume these are the groups of acini and the alveoli. For your understanding and product. So these are the groups of acini and the alveoli that are embedded around the larger alveolus. Normally, when the air moves through this bronchus, let us duplicate before that. So normally, when the air moves through a larger alveoli, like a bronchus, major bronchus, they are going to produce high-pitched sounds only. High-pitched sounds only. But as these sounds are transmitted through this alveoli, because this is the chest wall, let us assume, and you are putting a stethoscope here and you are trying to hear. You are putting a stethoscope here and you are trying to hear what is happening. So as they move through this alveoli will filter off the high-pitched sounds and they are going to transmit only the low-pitched sounds. That is the reason why normal vesicular breath sounds are actually low-pitched sounds only. You cannot hear this high-frequency sounds. This high-pitched bronchial breath sounds, you cannot hear because the alveoli filters off the high-frequency sounds. That is the reason the alveoli are also called as low-pass filters. That is why Laennec is the one who invented the stethoscope, and Laennec is the one who classified a lot of breath sounds. Initially, he called this as vesicular breath sounds. He was a little bit, not correct in calling this as vesicular breath sounds because these breath sounds generally did not originate from the alveoli. It originated from the airways only, but these are just filtered by the alveoli. Vesicle means alveoli. That's why Laennec called this as normal vesicular breath sounds. But what does happen in consolidation? In consolidation, I told you it's a filling process. It's a alveolar filling process. What the alveoli is filled with? The alveoli is filled with pus. So let us assume this area of the lung is filled with the pus. And here there will be alveolar collapse and the entire alveoli will be filled with pus as well. Because of that, these high-pitched sounds that are passing through this alveoli, which are generated from the bronchus, will come uninterrupted because now the alveoli are dysfunctional and they are not going to filter this high-pitched sounds, and you are going to hear this high-pitched sounds uninterrupted, not filtered by the alveoli with your stethoscope, and this is what we are going to call as bronchial breath sounds. But here, as usual, if the alveoli is very good, you are going to filter the high-pitched sounds and only low-pitched sounds will be heard from this region which is not showing any consolidation. Clear? Do you understand? So that is why in the area of consolidation you are hearing the bronchial breath sounds, and in the area which is not showing consolidation you will be hearing the normal vesicular breath sounds. Usually this bronchial breath sounds will be associated with increased vocal fremitus, always increased vocal resonance, and you have sounds like bronchophony and egophony. If you call what is egophony, egophony means it's E to a sound. So which means whenever you tell a letter E, it will be called as A. There's an interesting story behind this egophony. So what they generally found out is there was history behind that in China. So this was first discovered in China by a British physician. So in China it was under British colonization once upon a time in 1930s. That time there was an outbreak of pneumonia. During those times they used to screen the patients likely they are suffering from pneumonia by clinical examination. We didn't have that much of X-rays or sophisticated investigations that time. So hearing this bronchial breathing and hearing this peculiar type of sounds was the diagnostic point at those times. So when the physicians were examining, they wanted to test for your vocal resonance. How you test for vocal resonance? You tell 1, 1, 1, 1, 1 and you hear, and that 1, 1, 1 in consolidated area is going to be transmitted in a very high frequency compared to that of what is in the other areas. That increased vocal resonance is what we call as one of the classic hallmarks of pneumonia and consolidation. But in China, there is no English, nobody knows English, and when they were asked to tell 1, 1, it was not 1 in China, it was E in China. In Chinese, they tell E, 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 E. That is 1, 1, 1 for them. So the moment they told E, 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 the physician started hearing A, 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 A. So that's why this E to A sound, that's called egophony, came in clinical practice, and that became one of the accidental discoveries for consolidation. So this is something very beautiful to know the history of egophony in the first place. And later on they found out it's not the E only is getting transmitted to A, it's any of the vowels if you pronounce, they will be heard as A only. It means it's vowel to A sound, it's not like any of the vowels if you tell. Remember, vowels in every language is similar, it's A, E, I, O, U only. These are in every language if you take, this will be the vowels. So any vowel if you tell in a consolidated lung, the consolidated portion will transmit only A. And again it is because like the consolidated lung will transmit only certain particular frequencies that will be approximately around 1000, 1100 Hz. Only A is in the frequency of 1000 to 1100 Hz. Remaining all of the letters are above that or below that. So that is the reason why consolidated lung will, whatever vowels you tell, they will be transmitting only in the particular range. So that's why you hear everything as A. So this is what the origin of egophony, E to A sound, and this is a typical sign of a consolidation rather than a pneumonia. So these are, that's why I told you all these things I put under typical signs of consolidation. I didn't tell about the pneumonia. And most of the times I told you this consolidation and this bronchial breathing is associated with a very important chest X-ray sign called air bronchogram. So why do you get an air bronchogram? So if you take a lung, you have a lot of airways and surrounding parenchyma is there. So now the airways are going to contain air, and this air is going to look black, and normally the surrounding alveoli also are going to contain air, and they also look very homogeneous, and that's why it's very difficult to differentiate the alveoli and the like parenchyma from the airways. But what happens in a consolidated lung is the airways will contain air, fine, but the surrounding alveoli will get opacified. For example, you will get white filling because it's an alveolar filling process. Since it's a filling process, they get filled with pus, and the surrounding parenchyma look white, and you can see this as airways that are lodging this air very clearly as dark, and this is what we refer to as air bronchogram. And both are the same. The clinical finding of your bronchial breathing and the X-ray finding of air bronchogram has the same understanding. Like here also, the surrounding alveoli is filled with pus. It's an alveolar filling process, and that is the reason why the air is looking like very clear cut in the airways. That's what we call it as an air bronchogram. The whitish, like pus filled alveoli with the black air filled airways. So this is what the typical picture of a consolidation and air bronchogram. And this is the same reason why you get a bronchial breathing as well. So that is why many times whenever you have a bronchial breathing, it definitely must be associated with the air bronchogram if you suspect a pneumonia in the patient. Clear? So you are going to get a classic signs of consolidation in a typical pneumonia only, but you don't get that in a atypical pneumonia. The next thing are systemic features, systemic manifestations. If you ask about the systemic manifestations are generally very, very rare in a typical pneumonia, but extremely common in an atypical pneumonia. It could be GI symptoms also, but very common systemic manifestations will be headache and myalgia. Pathology wise, I told you it is alveolar filling process. It's filled with pus. Pus means it's going to be predominantly a neutrophilic infiltrate. Whereas here, it is an interstitial inflammation. It is not alveolar filling, it's interstitial inflammation, but predominantly they will have a lymphocytic infiltrate. Because these are atypical organs, that's why lymphocytic infiltrate. In chest X-ray, you are going to see typically a lobar pattern of pneumonia or a bronchopneumonia. Please do remember that lobar pneumonia is also a type of typical pneumonia, and bronchopneumonia is also a type of typical pneumonia. And the most common cause of lobar as well as bronchopneumonia in the world is pneumococcus only. Clear? So both, it's not different organs. Streptococcus pneumonia. So both come under typical pneumonia. Here you will see only interstitial infiltrates. You will see most of the time diffuse interstitial infiltrates will be there. That's what you're going to see in a chest X-ray. Leukocytosis, very, very, very common in a typical pneumonia. Very rare in a atypical pneumonia. At the same time, the organism that you are going to grow in a typical pneumonia is usually culturable. You can cultivate these organisms in that because these are bacteria, and lot of these bacteria are extracellular also, so it's easily cultivable, and you can grow these organisms in the culture medium. But these are not cultivable at all. Okay. Remember, the most common bacterial cause of a typical pneumonia is pneumococcus. Please give importance to my words. Bacterial cause of a typical pneumonia is pneumococcus. But the most common bacterial cause of atypical pneumonia, is going to be your mycoplasma, otherwise called as Aton agent, which we'll discuss later on. Mycoplasma followed by chlamydia, bacterial cause. Even Q fever, Coxiella burnetii can cause, rickettsial infection can cause this, but anyway, these are the two most important infections. But overall, most common cause of atypical pneumonia is virus. Virus is the most common cause of atypical pneumonia. I mean, identifiable cause at least. And similarly, your routine antibiotics in the sense, your beta-lactams, that's what I mean, the penicillin group of drugs, cephalosporin group of drugs work very well for a typical pneumonia, but they generally don't work very well for a atypical pneumonia because they are atypical organisms. Viruses don't respond to antibiotics anyways. These atypical organisms also, like Mycoplasma, Chlamydia, Rickettsia, they are not going to respond to your standard beta-lactam. They need your tetracyclines or macrolide antibiotics. So beta-lactams don't respond. Clear? So these are some of the very, very important differences between a typical versus atypical, and I hope you understand the concept of bronchial breathing and as well as the consolidation leading to air bronchogram. Now let us see the causes. Let us come to the causes of pneumonia. You will be stunned by one fact. This is a CDC chart that was published in 2017. So after that, they didn't publish anything like this, so don't worry. So what you can see is the fact that in almost 62%, that is the most common, isolated organism in a pneumonia patient is nothing. It means you don't know the cause, unknown organism, you don't know. This is the most common reason. Nobody believes that if I tell, but this is the exact CDC chart that I have reproduced. It is not my own chart. I have cut copy paste from the CDC chart, and you don't know the organism really. So you cannot cultivate an organism. No organism grows, and that is the most common cause of pneumonia. You don't know. You can see 23% are due to viruses. That's why I told you after this unknown cause, the most common cause of pneumonia is viruses only. In fact, atypical pneumonia, I told you most common cause is again viruses. And in that you can see the bacterial causes are very few. And among the atypical bacteria, Mycoplasma and Legionella and Chlamydia are the atypical. Chlamydia is not even in the table, not even in the pie chart. You can see Mycoplasma contributes to 2%, and among the atypical bacteria, Mycoplasma tends to be the most common. Atypical bacteria, Mycoplasma tends to be the most common. Among the typical bacteria, if you see here, Streptococcus pneumoniae is the one that contributes to 5%. See, astonishingly 5%. Like in identifiable cause of pneumonia, pneumococcus growth is isolated only in 5% of the cases. Mind-boggling. Like nobody would have even expected this result. Everyone as a typical undergrad, and even many of the postgrads think this is the most common, but it's only isolated in 5% of the pneumonia cases. Please be very, very careful. But still, it is the most common bacterial cause of a typical pneumonia. Or you can simply tell it's overall the most common bacterial cause of a pneumonia. Overall, the most common bacterial cause of a pneumonia. Most common bacterial cause of a typical pneumonia, this pneumococcus. But then what is the concept? Why we have to do this pneumococcal vaccine then? It's absolute rubbish, isn't it? No, it's not like that. Remember, giving a pneumococcal vaccine is something else. We do it for something else. We are not giving pneumococcal vaccine just to prevent the communicable pneumonia. We also are giving pneumococcal vaccine to prevent invasive pneumococcal disease like meningitis, because the most common cause of meningitis is also pneumococcus only in adults. It's not meningococcus. Only in adolescents, especially when they are transitioning from school to some hostel, that time they might get a meningococcal infection very commonly. But apart from the meningococcal infection, is generally very rare in an immunocompetent adult. It's only the pneumococcus that often causes the meningitis. So invasive pneumococcal disease, these vaccines can prevent. At the same time, in these patients who we don't know the causes, I told you idiopathic in almost 62% of the cases. In these cases also, it was presumed that majority of them are due to pneumococcus. Even though the culture yield is very poor, but we believe that majority of them in this particular group is also due to pneumococcus, but we don't have a concrete data to substantiate the fact. Only indirect data is there. By giving a pneumococcal vaccine, the entire community's incidence of the invasive pneumococcal infection is going to reduce. That's the only way. Anyways, fine. So these are some of the important data that you might be needing to know. This is for a cap. Please do remember, this chart is only for a community acquired pneumonia. We are not going to discuss about a hospital acquired pneumonia or a ventilator pneumonia, which is a completely different game, which we will be discussing later on. So again, let me recap. Most common cause of pneumonia is we don't. That's the most common cause. Most common cause of a typical pneumonia, or most common bacterial cause of a pneumonia. For both this, answer will be pneumococcus. Most common cause of atypical pneumonia is going to be viruses. Most common bacterial cause of atypical pneumonia, answer is going to be mycoplasma, latent agent. That's it. So this is what like the data tells, and this is what the latest data as well. That's what I'm going to tell as well. So let us move on to next one. So that is, what are the stages of a bacterial pneumonia, or the stages of a lobar pneumonia, typical pneumonia. This is not really important for your examinations, because this kind of questions has been asked way long ago. This has become a phylogenetic question, that too discussing on a lobar pneumonia, and like in this particular era is that too in a pathology and stages, and is not currently a standard one. But still, just for the completion sake, I am doing this. You have 4 stages. One is called congestion stage. Then one you have red hepatization stage, where your lung looks like a liver. Then you have grey hepatization stage, and finally you have resolution stage. Let us see the days. First, congestion is day 1. Day 2 to day 3 is red hepatization. and day 4 to day 7 is gray hybridization, and resolution is day 8 to day 28. That is up to 4 weeks. After the day 7, first week, you get the resolution stage. And similarly, red hybridization here, in the initial congestion phase, it will be like a lot of bacteria will be there. Let us put here. You'll have a lot of bacteria, numerous bacteria will be there, and it will be congested. It will be like so much of inflammatory edema will be there. So it is a exudates. Numerous exudate will be there. A lot of bacteria will be there. In red hybridization stage, again numerous bacteria will be there, and a lot of exudate will be there, and you will get a lot of inflammatory cells in this stage. Lot of inflammatory cells along with the exudate will be there. But why the hell your lung assumes a red texture? It is because these lungs will have a lot of fibrin acids. So that is the reason they assume that red texture. And what do you see in gray hybridization? Gray hybridization, your bacteria will be destroyed, so you don't see much of bacteria here. By the inflammatory cells, the bacteria would have been cleared off most of the time, and the inflammatory cells still will be present, but not that much like what you see in a congestion stage or a red hybridization stage. At the same time, the affected area will become a little bit grey and firm. So in the resolution stage, again the bacteria will be completely disappearing, and the inflammatory cells will be removed from that particular area. At the same time, you will have a purulent exudate, and there will be active ongoing fibrinolysis to remove the fibrin. Clear? So these are the different stages of the lobar pneumonia. Remember, this is applicable only for a lobar pneumonia. So you have to know the days only. But there's no point in actually knowing about like what is exactly happening in all these things, because this is not going to be a very really high yield thing for the exam. So these are the 4 classic stages: congestion, red hybridization, gray hybridization, and resolution phase. Clear? Now let us go to the risk factors and the associated organisms. What are the risk factors and associated organisms for a pneumonia? First, alcohol predisposes to certain organisms like pneumococcus, that is Streptococcus pneumonia, and your oral flora, because the risk of aspiration, oral anaerobes, again they can cause pneumonia in this patients, aspiration pneumonia and lung abscess, very common in alcoholics, and Klebsiella also increase in incidence in alcoholic patients. Then if you have a structural lung disease like bronchiectasis or cystic fibrosis, this is a very important point, please pay attention. Bronchiectasis and cystic fibrosis, again your staph aureus is going to be the most common cause, there is no doubt about that. But remember, very very notorious organism in these patients is Pseudomonas. Many times you will have a colony of Pseudomonas. Remember, this staph aureus will not form a colony, it's only a cause of pneumonia in these patients, but Pseudomonas will form colonization. Most common colonies you expect in this patient structure are these Pseudomonas colonies, that do the early stages of these diseases. Then it could be your Burkholderia capricea. This is a very very poor prognostic sign. Isolating a Burkholderia capricea from patient who is suffering from bronchiectasis, cystic fibrosis, it's going to reduce the survival definitely. Or it could be Stenotrophomonas maltophilia. Clear? And these are very very resistant organisms, and whenever you encounter these organisms, in these patients with structural lung disease, it's very very poor prognosis. They die very fast. It's very difficult to clear them out. That's why. And if you have a history of aspiration, remember, any patient with a low GCS or loss of consciousness, or patient had a seizure history, again you are going to increase the risk of aspiration. So typically you will have oral anaerobes, or you can have this gut organisms also because of vomiting and aspiration. Oral anaerobes or gut organisms like E. coli or any other enterobacteria, which means I am dealing about GAT organisms. So these are all is risk factor in aspiration. age more than 65. Notoriously, again, they are going to predispose to certain infections like influenza, pneumococcus, and pneumonia due to rhinovirus. That is due to low immunity. But remember, this pneumococcus is one thing which is very notorious in elderly patients, and definitely that is the reason why almost all elderly patients are vaccinated, whose age more than 60 with pneumococcal vaccine, which we'll discuss later on again. Post-viral, especially after an influenza or any other viral illness, they predispose to secondary pneumonia. We discussed this already. So what are the organisms? Again, in this particular group, pneumococcus tends to be the most common bacterial organism that cause pneumonia in this group as well. Or it could be a Staph aureus, or it could be a Streptococcus pyogenes also. But in exam, they will expect you the Staph aureus. But even though pneumococcus is most common in post-viral pneumonia, but they will expect you the Staph aureus in exam, because whenever in exam they give a viral infection or influenza-like infection prior to patient getting a pneumonia, always answer Staph aureus. That's what the examiner expects. And asplenic patients who are having asplenia, you're going to get Streptococcus, pneumonia, or influenza. Why Streptococcus pneumonia? I mean, because asplenia predisposes to infection with capsulated organisms, and that's why Streptococcus pneumonia being a capsulated organism, again is going to have a high risk. Okay. Animal exposure. Animals and your viruses. And what are the pneumonias you're going to get? First, rodent droppings. If they give history of rodent droppings in exam, go for hantavirus pneumonia. Hantavirus can cause, like your pulmonary renal syndrome. It can affect the lungs also, it can affect the kidneys also, and it can cause multi-organ dysfunction also. But typically, the death is due to pulmonary renal syndrome only. So it's not common in India, fortunately. Rodent exposure. Then cats exposure means you can think about Pasteurella multocilla. Pasteurella multocilla. And exposure to birds can give rise to Chlamydia psittaci, Histoplasma capsulatum. That is histoplasmosis, nothing else. Then Cryptococcus neoformans. Remember, Cryptococcus causes meningitis in immunosuppressed patients only, but very commonly in immunocompetent patients, it will usually cause lung infection only. Pneumonia-like picture, or a very subtle lung infection only they will cause. Cryptococcus, remember, again the primary site of infection is the lung, not the brain. Meningitis due to Cryptococcus neoformans is usually seen in immunocompromised patients. But there is one variant of Cryptococcus is there that can cause, like your meningitis even in immunocompetent patient. But still, Cryptococcus meningitis in immunocompromised people only. But still, the primary site of infection in Cryptococcus is the lung. So you have farm animals and domesticated pregnant animals. A lot of farm animals are there, and this predisposes to brucella. Remember, this is a very important history. Especially this animal contact is very important for diagnosing brucella, especially these farm animals, who's important for dairy products and all. So very important is brucella, and you can get Coxiella burgundii, Q fever also. Then rabbits. Rabbits exposure is very important for Francisella tularenii, which can also cause a pneumonia. Francisella tularensis. But I can add latest addition, bats exposure. Whenever they have a history of bat exposure, please think about your coronavirus related infections. This is the thing that I'm going to teach after the outbreak of these two types of coronavirus that has happened in 2003 and 2020 now again. One is the SARS and the second one is the novel coronavirus. So this could be a very potential question in your exam. Clear? So these are the important animal exposure and related organisms. In this, I strongly expect this bat exposure to coronavirus infections, severe respiratory infections. SARS is something again due to coronavirus, and this novel coronavirus in 2020 is again due to this coronavirus exposure from bats. It's supposed to be from bats. So clear. So these are the different association with animals, and you get an infection. So we have seen the specific, like risk factor associated with certain organisms. Now let us move to the diagnosis. How can you diagnose a community acquired pneumonia? Diagnosis, because we have entered into a fact of community acquired pneumonia. We are not discussing, I told you clearly in the beginning itself, we are not discussing on hospital acquired pneumonia or ventilator pneumonia yet. We have a discussion already, but right now we are not doing that. We are doing only discussions of community acquired pneumonia. So we are going to diagnose. Diagnose, obviously you will have, because this community acquired pneumonia most of the time can be typical or atypical, but if it's typical, many times you might have an elevated inflammatory markers, elevated throat count, elevated ESR, elevated C-reactive protein. But remember, all these things are very, very pronounced only in a typical pneumonia than a atypical pneumonia. So all these things are reliable only in a typical pneumonia, but it's very, very rare in a atypical pneumonia, very less pronounced. Next, your sputum. Sputum analysis. Definitely you are going to send this for a culture and sensitivity and a gram stain. Clear? And remember, the sputum cultures and all are reliable only if you have a high quality sputum. So when will you tell it's high quality sputum? So the sputum will be of high quality only if you have less than 10 squamous cells per hyperfill. Because whenever you have more than 10 squamous cells per hyperfill, it's very likely to be a spit one rather than a coughed one. So which means this sputum should not have been spit. A sputum which is not spit, instead it's coughed out and taken. See, this is coughing out. This is spitting. This is spitting. So a sputum which is not spit and coughed out and taken, and those which is going to have less than 10 squamous cells per hyperfill is considered as a high quality sputum, and that is the one that makes a sputum culture sensitivity and gram stain very reliable. So even though you do extensive sputum culture sensitivity and gram stain, I already told you almost 60% or to 65% of the cases will not yield any organs in culture sensitivity. That's a well-known fact. So that is also one of the reasons community acquired pneumonia is often treated with empirical antibiotics rather than waiting for the cultures, because it's serious disease, number one. At the same time, anyway you're not going to get the organism in almost 2/3 of the cases. So that is why you give the empirical antibiotics, like in the beginning itself, the moment you diagnose the community acquired pneumonia. Then chest X-ray. In chest X-ray you get different patterns depending on whether it's a lobar pneumonia or whether it's a bronchopneumonia or whether it's an interstitial pneumonia. Remember, only interstitial pneumonia in this will come under atypical pneumonia. Lobar as well as bronchopneumonia will be coming under typical pneumonia. Lobar pneumonia, typically you will be encountering opacities. That fluffy densities, cotton ball type of opacities, that is what is typical of a lobar pneumonia. That's what you will see because it's an alveolar filling process. There is acini and lobules that contain this alveolar and acini are filled with pus. So that's why it looks like cotton ball or fluffy densities. That's why you get this. So opacities, that's what is characteristic. And typically they will affect one particular lobe. That's why it's called a lobar pneumonia. One particular lobe. And they're going to have characteristically air bronchograms. Characteristically air bronchograms. At the same time, they might have very commonly a parapneumonic effusion. That's really common. Parapneumonic effusion. Parapneumonic effusion is the one that happens due to the pneumonia. Because the pneumonia, if you get an associated pleural effusion, that's called a parapneumonic effusion in general. It could be uncomplicated, it could be complicated. Uncomplicated means the organism is not invading the pleural space. Complicated means the organism starts to invade the pleural space. It's called a complicated parapneumonic effusion, which you'll see in some time. For all this classic findings, pneumococcus tends to be the most common cause. Obviously, the most common cause of a lobar pneumonia is again pneumococcus. Then let us see on the bronchopneumonia. In bronchopneumonia, you will get a patchy and multifocal infiltrates. You will not get a focal in a single lobe. you will get a very patchy and multifocal infiltrates throughout the, but you generally don't get Arab bronchograms in this. Very unusual. You don't get Arab bronchograms in this, but instead you will get a typical same fluffy kind of densities, but multifocal infiltrate like fluffy densities you will get in different areas of the lung. So that's a bronchopneumonia. I'll show you the picture in some time. If you have an interstitial pneumonia, interstitial means they will have reticular densities because it's an interstitium of the secondary pulmonary lobe. So you will get reticular opacities, and you will definitely won't get any Arab bronchogram or signs of consolidation. Typically, there will be reticular densities that are going along the interstitial area. So this is typical of interstitial pneumonia, and very commonly this will be seen in atypical organisms. Remember, even for a bronchopneumonia, most common cause must be pneumococcus only because it's coming under typical pneumonia. That's it. For atypical, most common identifiable cause will be viruses. If they ask you bacterial cause, then it will be mycoplasma. So these are the different X-ray imaging findings in the CAP. Then what about the CT? CT is just an additional tool that will tell you your X-ray findings more correctly. It will confirm your X-ray findings. But apart from that, if you see all these findings in X-ray itself, there is no need for a CT. In fact, you don't even need a CT for that case. You just need a X-ray to diagnose a common-acquired pneumonia. But certain other few tests you can do, like urine test or not. But before that, let us see some images. You can see this particular image where this is a typical Arab bronchogram. Let me draw you and show. So this is the bronchus that you are seeing, and surrounding you are seeing this white patch. So this is a typical example of an Arab bronchogram where you have a black air in the airway bronchus, and you are seeing a surrounding patch of consolidation, and that is the surrounding patch of consolidation. That's white density. So this is an Arab bronchogram. And you can see this typical Arab bronchogram in the CT also. You can see these are the areas that are containing air, and again these are the pus-filled alveoli that are surrounding the bronchus that is containing air. So that's why it's called an Arab bronchogram. Typical sign of consolidation. And this is one important sign which I didn't tell you. So this is referred to as something called a bulging Fisher sign. Bulging Fisher sign. In exam, if they ask you where will you see bulging Fisher sign, you have to answer Klebsiella. You have to answer Klebsiella. But practically speaking, you can have this bulging Fisher sign as any bacterial pneumonia. It's not like only for Klebsiella. Any bacterial pneumonia can have a, or any consolidation can have a bulging Fisher sign. But typically, like go for Klebsiella in case if it's an exam. This is an example of a bronchopneumonia where you are seeing a lot of multifocal. These are also fluffy opacities only, but a lot of multifocal patchy opacities you are seeing here. These are also multifocal patchy opacities only. So this is typical of a bronchopneumonia. Again, most common cause is pneumococcus. And again, another example of a Arab bronchogram in the CT. You can see these are bronchus that are airways that are filled with air. These are airways that are filled with air, and the surrounding you are seeing a pus-filled or filled alveoli. It's an alveolar filling process. And you can see another area here also. This is also an example of an Arab bronchogram. And here you don't see that much of Arab bronchogram, but still you see alveolar filling with some material. Here it's the pus. So which means you are seeing in multiple different areas consolidation in Arab bronchogram. So again, this is a bronchopneumonia in the CT. Here these are interstitial infiltrates. You can clearly see again. So these are interstitial infiltrates that are going patchy like this in many areas. You can see this is all this in the upper lobe predominantly. Both sides you are seeing. Predominantly in the right side upper lobe you are seeing. This is a typical interstitial pneumonia or atypical pneumonia. And one more important fact to note that is, even though you start antibiotics for pneumonia, it will typically take 4 to 6 weeks for resolution. It will not resolve Like you think if you start antibiotics today, after 1 week, if you take an X-ray, still the consolidation will be there. It might take around 4 to 6 weeks, because if you see the pathology of a lobar pneumonia, what you have read there is the resolution phase starts from the 8th day, that is after a week, and it goes up to the 4 weeks. But in general, the X-ray or radiologic resolution of a pneumonia might take around 4 to 6 weeks. So after 6 weeks only, you should take an X-ray if you want to repeat the X-ray and see the CT or whatever. But before that, if you take, you might have some residual signs of consolidation or a pneumonia. So which you should not misinterpret as an active pneumonia. So that's why radiological pictures are many times confusing if you don't do them properly. Okay, then I told you some other investigations also you can use, like urine you can use. In urine, there are two testings are available. One is called legionella antigen testing and pneumococcal antigen testing. These are very good. Pneumococcal antigen testing. If you suspect Legionella pneumococcus, you can do a urine antigenesis for this. Then PCR is available, and PCR is needed only for diagnosing chlamydia, and it's the gold standard for diagnosing chlamydial infections. And pleural fluid analysis is warranted. Diagnostic pleural fluid analysis, I'm not telling therapeutic thoracosynthesis. Diagnostic thoracosynthesis you can do and take a sample for pleural fluid analysis if the patient has an evidence of parapneumonic effusion. Parapneumonic effusion. These are very important points. If the patient has evidence of parapneumonic effusion. Clear? I'll tell you what is the importance of doing this, because if it's a complicated parapneumonic effusion, which means the bacteria starts invading the pleural space, you will have some signs in the pleural fluid, some diagnostic findings in the pleural fluid that will tell you it's a complicated parapneumonic effusion, that the organism tends to invade the pleural space. If you give only antibiotics to these patients and if you don't drain this kind of pleural fluid, which is having complicated parapneumonic effusion, the pneumonia will not resolve and the fever will continue and the signs of pneumonia also will not resolve. So you will be thinking like an antibiotic failure, but it's not the case. It might be a sensitive organism, but just remove the fluid and make that area free, and the pneumonia and fever will resolve. It's a very important thing to do. Any parapneumonic effusions, if we have, and if it's something aspiratable, we have to do a diagnostic thoracosynthesis to do pleural fluid analysis. We can see some important things about air bronchogram. Some myths and understandings about air bronchogram. First of all, to think this air bronchogram is a sign of pneumonia is itself wrong. It is non-specific for a pneumonia, which means it can be seen in any condition. That is associated with consolidation. So what is consolidation? You need an alveolar filling. This alveolar filling, the filling can be by blood, or the filling can be by pus, or filling can be by water also. Clear? So any alveolar filling process can produce consolidation, which in turn can produce an air bronchogram. So it means it's not specific thing for pneumonia. Second thing, usually air bronchograms are associated with bronchial breath sounds, because the mechanism of bronchial breath sounds and the generation of air bronchogram are both the same. Alveolar filling with intact larger alveolus in the surrounding. So what are the differential diagnoses for air bronchogram? Any condition that produces consolidation, I told you. Apart from that, pulmonary edema, where it will be filled with water. Then you have severe interstitial lung diseases that can produce these air bronchograms. Then you have something called a non-obstructive atelectasis. Obstructive atelectasis generally don't show the air bronchograms. Non-obstructive collapses, non-obstructive atelectasis tend to show air bronchograms. Then certain cancers like bronchoalveolar carcinoma. Bronchoalveolar carcinoma. So diffuse alveolar hemorrhage or simply pulmonary hemorrhage, obviously again it's an alveolar filling process. Then pulmonary infarction. Pulmonary infarction can also show air bronchograms. Finally, Normally itself you can see air bronchograms during expiration. Expiratory films may show air bronchograms physiologically itself. That may be because some of the alveoli might collapse and the air may still be intact in the bronchus showing an air bronchogram. So that is also one reason why your films should be taken in inspiration, full inspiration. Then only, typically in a PA view, you do inspiration, that time only they take the film. They don't take the films in expiration because it's going to result in a lot of other problems apart from showing the air bronchograms. So these are the differential diagnoses for air bronchograms. Suppose if you are suspecting a pneumonia, whenever you have an air bronchogram, you are suspecting a pneumonia and you are treating with antibiotics. Simply I'm doing a case scenario where you are treating this pneumonia with antibiotics, and if the air bronchograms are not resolving, next step if they ask you, do a CT. That is the next step. Why? Because it could be a malignancy. Because sometimes a malignancy can mimic a air bronchogram. If it's not resolving by antibiotics, means you have to take a CT for sure. There is no doubt about that. Or any conservative matter. Unresolving air bronchogram needs a CT for sure. Okay. Now we have seen a lot of things about the basics and all this stuff, but right now we are moving on to the actual therapeutic aspects. First, assessment of the severity. Because based on the severity assessment only, your treatment is also there. Apart from this scores, what I am going to tell, are going to tell your prognostication. They are also judge your treatment as well. They also guide your treatment. So what are the severity scores? There are two severity scores that are very important. One is called a curve 65 score, and second one you have something called a pneumonia severity index, PSI, pneumonia severity index. But what is preferred is the pneumonia severity index only because of its accuracy. But what is actually easy is this curve 65 score because of the non-complicated 5 data that you're going to see in a curve 65. What do you mean by curve 65? Number one, your C stands for confusion. It's a, curve 65 is actually a expansion, what you can do from the acronym. So C stands for confusion, which means any mental test score less than 8 out of 10. So it goes towards, MTS means mental test score. It goes for this curve 65 confusion. Then U stands for urea, that is blood urea nitrogen more than 20 milligrams per deciliter. 20 milligrams per deciliter. Then R stands for respiratory rate more than 30 per minute, and B stands for BP, that is either systolic blood pressure less than 90 or a diastolic blood pressure less than 60, hypotension. And 65 means age more than 65. So that is why we call this score as curve 65. Clear? Each and everything is going to carry 1 point, which means the score ranges from 0 to 5, obviously. So 5 components are there, so score is going to range from 0 to 5. What about this pneumonia severity index? It's a little bit cumbersome, and it's a 2-step protocol, pneumonia severity index. It involves 2 steps. So let us see what are the steps. One, you have step number 1, which you use for screening. If any of the steps are seen, if any one of the screening things which I am going to tell are present in step 1, then you have to proceed ahead to step 2. Clear? You have to proceed ahead to step 2. Step 2 is generally not needed for you because it's usually done with an application or a computer-based scoring system is there. But anyway, at least the screening points you have to know. Suppose what if the screening is negative. Suppose if you don't have any of the points that are given in the screening protocol, then automatically your pneumonia will become a class 1 pneumonia. But if you have something positive in step 1, any of the screening points are seen in the patient, then you have to go to the step 2, and now the patient will be assessed as different class of pneumonia. For example, they can be a class 2 pneumonia, or a class 3, or a class 4, or a class 5. Class 5. Clear? So in the step 2, when you call class 2, it's a computer based score already, but if you get a score of less than 70 in step 2, that is called a class 2 pneumonia. If you get score in between the range of 71 to 90, that's a class 3 pneumonia. If you get score in the range of 91 to 130, that's a class 4 pneumonia, and anything more than 130, that is anything more than equal to 131, it is a class 5 pneumonia. So it depends on the step 2. If all the screening points are negative in step 1, then automatically pneumonia will be assigned as class 1 pneumonia. So what are the screening points that you have? It's a little bit similar to your curve 65 in the sense that this also will include a confusion. This will not include urea, instead I'll tell you what it will include. This will include a respiratory rate of more than or equal to 30 per minute, R is also there. And again it will include BP in the form of SBP less than 90 millimeters of mercury. And it will include the age also, but here it's not 65, it is age more than 50. So which means almost 4 of the 5 components of curve 65 is included in the pneumonia severity index also as a screening protocol. But apart from that, pneumonia severity index also utilizes some other extra features like comorbidities. In that, that's a very important point. Comorbid status like malignancy, cerebrovascular disease, pain or something, stroke, and all these things. CKD patients, chronic kidney disease patients, or liver disease patients, or congestive cardiac failure patients, heart, liver, kidney, then CNS disease, and stroke like things, and malignancy, all these things will put under comorbid. So comorbid features also carries a separate this thing in the screening. Apart from that, temperature is included in this, whether it is less than 35 degrees Celsius, reasonable hypothermia, or if it is more than 40 degrees Celsius, very severe fever. So both are considered as one of the points in screening of a pneumonia severity index. Then your heart rate is included here. If it is more than or equal to 125 per minute. So again, it is one of the screening points in the pneumonia severity index, which means it's almost similar to curve 65, with the exception of age is there. Apart from that, urea is not there, blood urine nitrogen is not given here. Plus, instead of urine blood urine nitrogen, everything is put under comorbidities. Kidney is also come under comorbidities. That's why comorbid status is there, heart rate is there, and temperature is included. So this is what we call the screening tool of the pneumonia severity index. If you want to do the real step 2, download any like this clinical apps and you can see the pneumonia severity index. It's usually a computer-based tool. It's a software-based assessment. So this is how you are going to classify the severity of the pneumonia. The higher the score, the higher is going to be the severity. For example, curve 65 score of 0. And one probably tell you might go for an OP treatment. It's not that serious. Score of 2 will tell you probably you might need a short IP care. 3 or more, which means you need a definite IP care. Clear? So you can tell by curve 65 score how to tell your treatment also. At the same time, more the score is, more worse is going to be the prognosis. More severe is going to be the pneumonia, and more sick the patient is going to be. So let us see now how it's going to guide the treatment. So now you have a curve 65 score. You have a curve 65 score, and you have pneumonia severity index, and what is the proposed treatment plan. If curve 65 score is 0 or 1, and if pneumonia severity index, if it's class 1 or class 2, then you can do a OP treatment itself. You don't need to do anything. You can just give OP, oral antibiotics, and you can send them. In fact, you can give oral antibiotics and you can send them empirically. If it's 2 here, or if it's class 3 here, he might be needing a short IP care, like an observation type of a scenario. Rather than a full-blown IP, you can do a short IP, maybe 1 or 2 days of observation, how they are going upon, how they are going to work upon, and then you can decide on the discharge. If it's anything more than or equal to 3, or if the patient is class 4 or 5 in PSI, let me write class. So class 4 or 5 in a PSI, then definitely they need a inpatient care. At the same time, they might be needing a ICU stay also. But remember, none of this scores, this curve 65, PSA, none of this scores predict ICU admission very clearly. At the same time, these scores are very highly sensitive, but they are very poorly specific. In the sense, they can detect almost all the patients. The scores are high, which means definitely they will be having severe disease. But if the scores are low, it doesn't mean it indicates very low severity disease. That is why these scores are not that good for predicting the severity as such. especially the ICU admissions. So that is why for predicting the ICU admissions and the real severity of the impact of CAP, community-acquired pneumonia, we have different other scores, like you have a SMART COP tool, then you have a SCAT score that's called a severe community-acquired pneumonia score, then you have ATS, IDSA severity tool. ATS means American Thoracic Society, IDSA means Infectious Disease Society of America. So ATS, IDSA severity index. So these are the three tools, but I strongly believe the SMART COP could be an exam question. Where you use SMART COP tool, even again knowing this is an acronym for a lot of features, which I will tell you later on if it's really needed. But anyway, this SMART COP, the name can be asked in exams. That's a thing score that predicts your ICU admission. Clear? And at the same time, this curve 65 PSI and the SMART COPs, CAP, ATS, IDSA guidelines, all these things can be applied only for community-acquired pneumonia. To be very, very clear about that, curve 65 is a score for community-acquired pneumonia, and PSI is again a score for community-acquired pneumonia. You cannot use these scores for your hospital-acquired pneumonia, ventilator pneumonia, which is having a separate set of parameters to discuss with. So you don't see all these things. You just use this for a community-acquired pneumonia. And remember, this curve 65 PSI is not going to predict real severity, and ICU admissions are very badly predicted. Even though they have a high sensitivity, they have very poor specificity. So the better tools for predicting ICU admissions are SMART COPs, CAP, and ATS, IDSA severity score. Now how can you treat? Really? Now we know only the OP treatment or the IP treatment. So let us move on to the actual guidelines on how to treat an pneumonia. So whenever you encounter community-acquired pneumonia, so you have to know about the treatment decision, whether you're going to treat as an OP or an IP in the first place. Let us assume my curve 65 score is 0 or 1. Curve 65 score of 0 or 1, or PSI class 1 or 2. PSI class 1 or 2. On the other hand, I can put curve 65 score of more than or equal to 2, or PSI class more than or equal to 3. So these patients I am going to decide that I am going to treat by OP, even though not always. And these patients I can decide that I am going to treat as an IP or an ICU plan. If I have decided to treat this patient as OP, I know I have to give oral antibiotics only. So in this case, I have to ask only one question, that is there any antibiotic use in the last 3 months, that is in the last 90 days, or if the patient has any comorbidities. If the answer to any one of the questions is yes, or answer to the questions are no, the answer to any one of the questions is yes, and the answer to this question, both the questions are no, what you will do in this regard. So the answer is no to both the questions, which means the patient is not using any antibiotic in the last 90 days and the patient has no comorbidities as such, then you can just use a macrolide, your favorite, like azithromycin. Just a macrolide therapy is more than enough. Suppose if the patient has any one of the questions, yes, suppose if they have used antibiotic in the last 3 months, or if the patient has some comorbidities, then in this condition, you can use a respiratory quinolone. Very common example of respiratory quinolone is 3rd and 4th generation quinolone. In that 3rd generation are so commonly used, that is levofloxacin. Clear? So you can use a respiratory quinolone, or you can use a combination of a beta-lactam drug and a macrolide. So very common beta-lactam drug that we use is amoxicillin clavulanic acid, or oral drug. We talk about oral drugs, which is OP treatment. So amoxicillin clavulanic acid, you can use your cefpodoxin or any other 3rd generation cephalosporin like cefixime, or a 2nd generation cephalosporin like cefuroxime, 1st generation like cefalexin. But in general, I prefer a 3rd generation or a 2nd generation cephalosporin like cefuroxime, cefixime, or cefpodoxin. So this is what we prefer. At the same time, you can prefer a beta-lactam like amoxicillin clavulanic acid also. So this is oral drug, excellent oral drug. So plus along with it, we'll add a macrolide like azithromycin or clarithromycin. Anyway, so this is how we are going to treat. But suppose if the patient is planned to be treated in IV or ICU, very likely I am going to prefer an IV antibiotic. So in this condition, again I can split into patients who are not having an ICU care or those who are present in the ICU. So those who are not in the ICU, again I am going to treat like the same, like these kind of patients only who had antibiotic use in the last 3 months or who are having comorbidities. So like for example, I am going to use a respiratory quinolone, typically levofloxacin, or I can use moxifloxacin, doesn't mean anything. So respiratory quinolone, or I can use a combination of a beta-lactam with a macrolide. If the patient is in IV admission, the beta-lactam that you generally prefer is like a cefotaxime or a ceftriaxone. So that's a commonly used drug. If the patient is in ICU, so you have to use any one of the combination which I am telling you. So you have to use a beta-lactam drug for sure. Here the beta-lactam becomes a mandatory drug. Definitely you have to give a beta-lactam. Typically in ICU setting, we tend to prefer, you can do a ceftriaxone, but in ICU setting we generally go for piperacillin tazobactam. Or in worst case scenarios, if we suspect Pseudomonas resistant drug, then you can even go for a meropenem or imipenem or a etapenem also. Etapenem is not going to cover Pseudomonas well already, but we'll discuss that separately. But anyway, some beta-lactam you have to prefer. Very commonly we prefer a piperacillin tazobactam. It could be a cefoperazone sulbactam or even a ceftriaxone. That is your wish. But I prefer piperacillin tazobactam as my favorite. So beta-lactam plus any one of the drugs you can give. Like you can give a macrolide, or a respiratory quinolone, like levofloxacin or moxifloxacin. Again, you are going to give any one drug only. Definitely you have to give any one drug. There is no drug. Any one drug only you have to prefer among the two. So very, very important point here. Clear? So this is what you do in the ICU. Suppose some some additional things you have to consider here. For example, for a macrolide, I have used macrolide in a lot of areas here. Macrolide here. Instead of this macrolide, the alternative, what I can use is doxy. Doxycycline can be used as an alternative instead of a macrolide. But I didn't tell doxycycline here. Why? Because doxycycline is indicated only in OP and non-ICU patients. Only in OP and non-ICU patients you can use doxycycline as an alternative. But in ICU patients, generally doxycycline is not indicated. That is because of the poor efficacy in trials of doxycycline in ICU patients. That's why we don't use them. Okay. So we are also telling the fact that respiratory quinolone in a lot of areas. What do you mean by respiratory quinolone? As I told you, if you if you want to know what you mean by respiratory quinolone, it's nothing but the third and fourth generation quinolone. So what we call as respiratory quinolone. The classic trademark example of a third generation quinolone is the levofloxacin. Even though you have gemifloxacin also, but we generally don't use that so often. So levofloxacin is such a commonly used third generation fluoroquinolone. And the fourth generation quinolone means you are cautiously going to use a moxifloxacin. Even though the sparfloxacin and all these things we are going to use, not going to use very commonly. The moxiflox becomes a very common drug in your routine setting. Levofloxacin dose is generally 500 to 750 mg once a day dose, and moxifloxacin generally it is 400 mg once a day dose. Both are available as oral as well as IV drugs. But anyway, these are the drugs that we are going to prefer as a third generation or a fourth generation cephalosporin. Sorry, fluoroquinolone. Clear? Alright. So this is how you are going to treat. And OP choice I told you, all these things choices I told you already. Is there anything that is left? I don't think so. Then I have to tell about the additional considerations. What about the additional considerations? For special organisms. First special organism is MRSA. Remember, here we are dealing about a community acquired pneumonia. It's not a hospital acquired pneumonia. Which means the MRSA concern means it should be a community acquired MRSA. Very, very important. It's not a hospital acquired MRSA, it's a community acquired MRSA because we are dealing with a community acquired pneumonia. So what are the drugs you can use? Usually, we will be using either vancomycin. Additionally, you have to add to the empirical therapy what I have told some time back to the algorithm. You have to add these drugs if you have a concern for MRSA, that is community acquired MRSA. We have to add vancomycin or linezolid plus a clindamycin. Plus a clindamycin is a standard therapy that should be added to the regimen with what I have told you already. If you have a concern for a community acquired MRSA, remember why you add clindamycin, especially in this community acquired MRSA groups. We don't add for hospital acquired MRSA. Typically, clindamycin is not generally preferred for hospital acquired MRSA, but generally used only for a community acquired MRSA. Why? Because this community acquired MRSA tends to produce a very important toxin called PVL. That's called Panton Valentin Leukocyrin. Clear? So that is the reason why to down-regulate this toxin, because this toxin is a protein, isn't it? And you give clindamycin, which is a very powerful protein synthesis inhibitor. So that down-regulates the toxin synthesis. That is the reason why you give clindamycin. Clear? And clindamycin in this setting particularly it inhibits the protein synthesis of especially gram-positive bacteria. Remember, metronidazole and all these things work are anaerobic but they work more on gram-negative organisms. But a clindamycin spectrum is more towards the gram-positive spectrum. That's why you're using for MRSA, community acquired MRSA, to down-regulate the toxin synthesis. So this is the standard therapy. Number 2, if you have a suspicion of Pseudomonas, you have to give a anti-pseudomonal drug. Your anti-pseudomonal drug should be there in the regimen. Remember, many beta-lactams are anti-pseudomonal. Suppose if you want to know what are the anti-pseudomonal drugs, we generally give a mnemonic called Campfire, where C stands for carbapenems, A stands for aminoglycosides, and M stands for monobactams, P stands for peptide antibiotics or polypeptide antibiotics like colistin and polymyxin B. Even though we have a separate bonus content at the end of all the lectures, we'll be recording that. A bonus content on antibiotics and infectious diseases and infectious organisms that are going to cause. But right now, trust me, this is the least minimum that we have to know. And this F stands for fluoroquinolones. Typically only second and third generation fluoroquinolones. First and fourth generation does not cover. That is again very important point to know. And your IR will stand for third generation cephalosporins, and only one third generation cephalosporin generally covers, that is ceftazidime. But remember, now this also is usually not preferred because of the emergence of resistance. Now ceftazidime we don't prefer. Like when I was discussing about this topic in 2015 itself, that time itself, one of the ID specialists have questioned me the fact that how can you give ceftazidime to a patient when I was discussing in a social work. So that time itself the resistance started emerging. Right now we are not going to use that much of ceftazidime. Instead, currently 4th generation cephalosporins are said to be extremely sensitive to Pseudomonas. So if at all you prefer a cephalosporin, prefer a 4th generation cephalosporin, that is Cefipan. Very, very excellent for pseudomonal cover as of now. We don't know the resistance pattern, it's only emerged after 2 years or 3 years, but right now Cefipan is a very good drug. And you can give extended spectrum beta-lactamases. Please note that this is not a pharmacology session, and what I am going to really use is this piperazine tazobactam. This is what I am going to use typically. We have ticagrelor clavulanic acid combination also, but again I am telling this is not a pharmacology class. I am talking about the practical aspects. This piptazole is one of the extended spectrum beta-lactamases, or your anti-pseudomonas. Not beta-lactamases, sorry for that. In the flow I wrote that. It's a beta-lactam, extended spectrum beta-lactams. Again, remember, this is also referred to as anti-pseudomonal beta-lactams or anti-pseudomonal penicillins. Anti-pseudomonal penicillins or extended spectrum penicillins. Because in penicillin you have a lot of groups. You have initial natural penicillins. Best example is your penicillin G, penicillin B. Then you have aminopenicillins, that is nothing but your amoxicillin, then ampicillin, all these things will come. Aminopenicillin starts with AM. Then you have your anti-staphylococcal penicillin, that is nafcillin, cloxacillin, dicloxacillin. Then 4th came the anti-pseudomonal penicillins. That is piperazine, tazobactam, ticagrelor, clavulanic acid, and all these things. Clear? So these are the drugs that are effective for pseudomonal cover. In that, you can see a lot of beta-lactam drug because we are using beta-lactams already. You can see beta-lactams are used here, beta-lactams are used here, beta-lactams are used here. So which means in the community acquired pneumonia protocol, a lot of places we are using a beta-lactam. So let us isolate the beta-lactam. What are the beta-lactams that are seen here? Carbapenem is a beta-lactam. This monobactam is a beta-lactam. This cephalosporin 4th generation, 3rd generation beta-lactam. Then this extended spectrum penicillin. This is also beta-lactam, which means you have all the 4 groups that are available. Like whenever you talk about beta-lactams, you have 4 groups which have this characteristic penicillin ring. So what are the 4 groups? One is your penicillins. This is a beta-lactam ring. Let us assume it's a pentagonal structure, but I'm putting a square because I'm going to discuss about beta-lactams. Penicillins, then you have cephalosporins, then you have monobactams, then you have carbapenems. Each and everything has a lot of drug. So in this monobactams, we are not going to use routinely. Only in special circumstances we are going to use this monobactam. Only when you have a documented penicillin allergy, then only you can use monobactam. Why you can't use cephalosporin or why you can't use a carbapenem in a patient who is having a documented penicillin allergy? Remember, there is some risk of cross reaction is there, but even though the risk of reaction is very, very low practically, you can still use, even in a patient penicillin allergy, you can use cephalosporin and carbapenems. But for a legal perspective and for theoretical perspective in the textbooks, you cannot use, because even though the risk of reaction is less than 2% and less than 1%, still there is some risk of cross reaction to these antibiotics if the patient is having a known penicillin allergy. But remember, this monobactams has 0% cross reactivity. That is the reason why monobactams are the preferred choice in any patient with penicillin allergy. There is absolutely no cross reaction. Clear? And the monobactams, only one drug is there. That is aztreonam, that is very commonly used. Typically, this is used in ICU patients. Suppose, let us come back to the algorithm. In ICU patients, if they ask, what is the monobactam that you are going to use? What is the drug that you are going to use in a patient with a penicillin allergy? Suppose if they give an additional choice that the patient is having a penicillin allergy, I am going to use a aztreonam instead of a beta-lactam. That's it. Just I am going to change the beta-lactam to aztreonam. I am not telling instead of beta-lactam you use aztreonam. The beta-lactam that you are going to use there is aztreonam. That's it. Nothing else. Simple. So because aztreonam has 0% cross reaction, absolutely no cross reaction with any patient with penicillin allergy. It's just an adjustment. I'm not telling it's something completely different. It's just an adjustment that you're going to do. The beta-lactam is what you're going to use, but still the beta-lactam that you'll be preferring is aztreonam here. If the patient is having a penicillin allergy, especially in ICU patients. Non-ICU patients, it's fine. We have a lot of other options, but in ICU patients, we have to definitely use beta-lactam, isn't it? In non-ICU patients, you have an option. You need not use a beta-lactam. In OP patients also, you have an option. You need not use beta-lactam mandatory. But in ICU patients, surely you need a beta-lactam. That's why in these patients, you need aztreonam if the patient is having a penicillin allergy. At the same time, what is the best combination with aztreonam? If they ask you, it's a respiratory control. Macrolide doesn't go well with aztreonam due to unknown reasons. Macrolide doesn't work that much well with aztreonam, but with aztreonam, the best is respiratory control. Clear? So these are the anti-pseudomonal drugs. So what I am trying to tell here is, I told you have 4 different groups of beta-lactams that are anti-pseudomonals. Your carbapenems are anti-pseudomonal, monobactams are anti-pseudomonal, 4th generation cephalosporins are anti-pseudomonal, 3rd generation to an extent, and your piperazine, tazobactam and extended spectrum penicillins are anti-pseudomonal. What I am trying to tell is, if you have a pseudomonal cover, if you have a pseudomonal thinking in your mind, if you have a suspicion for pseudomonal infection, possibly, then the beta-lactam that you are going to prefer, must have an anti-pseudomonal characteristic. That's all. Which means the beta-lactam that you are choosing in the inpatients, IP patients especially, must be one of these 4 drugs. If you have a pseudomonas in your mind, possibly in this patient who is suffering from a pneumonia. For that matters, what are the carbapenems that are effective? Doripenem is supposed to be the most effective, but even though it's not commercially available that commonly in India at least, But in India, very commonly available is imipenem, meropenem. Both are very, very, very effective for Pseudomonas. But one drug that is actually not that effective for Pseudomonas, but very commonly available in India again, is ertapenem. Ertapenem, even though it's very effective for ESBL producing organisms as gram negative, other gram negative organisms that produce ESBL, it's not as effective for Pseudomonas. Very important point. Dori is most effective. Imipenem, meropenem are still very good, but see, this is what we prefer in our practice routine. But what about this polypeptide antibiotics? This peptide antibiotics which I told you, which is in this group, this peptide antibiotics, colistin and polymyxin. Remember, these are highly effective for Pseudomonas again. In fact, these peptide antibiotics are gold standard for any gram negative. These peptide antibiotics are gold standard for any gram negative because they act on the target, like the LPS that does in almost every gram negative organism. But still, you should not use it as a first line because these peptide antibiotics, colistin and polymyxin, are our last resort and it should be reserved for only MDR organisms. Even though that can be used in and out for any gram negative, but it should be reserved only for MDR because it's our last resort. We have to use only in MDR organisms because we don't have any other options after this. But even though we tell gold stand for gram negative, there are certain gram negatives which don't respond to this colistin, polymyxin also because they are intrinsically resistant. Naturally itself, they don't respond to these drugs. That is Serratia, Proteus, and Burkholderia. These are very important to know. So these are the three organisms. Even though they are gram negative organisms, they do not respond to polypeptide antibiotics because they are intrinsically resistant to this antibiotics. Naturally resistant. They don't work. But apart from that, for any other gram negative like Klebsiella, Pseudomonas, E. coli, if they are MDR organisms resistant to multiple drugs, you can try colistin or polymyxin. But apart from that, do not use or do not even talk about these antibiotics for routine cases because you are going to screw up yourself. Please, you have only these antibiotics for the last. Don't save for the last. Save water. You save these antibiotics. Don't use them unnecessarily. And in that monobactams, I am going to use only in case of penicillin allergy. Apart from that, I am not going to use this monobactam. That too in ICU patients only. OP you have an alternative. Non-ICU you have an alternative. So only in ICU patients, I am going to use this monobactam Castronum as an alternative to beta-lactam in patients with penicillin allergy. That brings me to a conclusion. You have first line choices, first line drugs for anti-pseudomonal cover, first line anti-pseudomonal cover, which you have the number one drug, that is your anti-pseudomonal penicillins. Anti-pseudomonal penicillins, typically your piperacillin, tazobactam. Then you have fourth generation cephalosporin, that is cefepime. I told you ceftazidime is theoretically okay, but practically right now we don't use because of the emergence of resistance to ceftazidime from Pseudomonas. Then third one, what we can prefer right now is the carbapenems. Typically doripenem, imipenem or meropenem, but in our practice we use meropenem. I'm telling an example. You can use imipenem, I don't have any problem. So these are the three characteristic first line drugs I'm going to use for any anti-pseudomonal because these are also, remember, beta-lactam drugs. Beta-lactams are cidal, so prefer a cidal drug. This is what I'm going to use. What are the second or alternative drugs? Not alternative drugs, these are add-on drugs. I'm not going to use these drugs as a main drug, but I can use as an adjunctive add-on drug. Most important add-on drugs are two, which we have not discussed in this chart. That's a fluoroquinolone and the aminoglycosid. These two we have not discussed at all. So you can use an aminoglycosid, typically like an amikacin example I can use. Gentamicin also okay, but gentamicin spectrum is more towards a gram positive. Amikacin spectrum is more towards a gram negative, but still amikacin works only for aerobic organisms. So aminoglycosides work only for aerobic organisms, and they don't work on anaerobic because their entry into the cell is oxygen dependent, so they can't work on anaerobic organisms. Anyway, aminoglycosides are definitely IV only. You cannot use orally, which means you cannot use these drugs for treating a OP committed pneumonia. You have to use only in IV patients when you are going to use an IV aminoglycosides. Second alternative drug that you can prefer is a adjunctive drug or add-on drug that you can prefer is a fluoroquinolone. Again remember, only second and third generation fluoroquinolone are anti-pseudomonal, which means best example for second generation is ciprofloxacin, best example for third generation is levofloxacin, very commonly used drugs in our practice. Cipro 1, levofloxacin. Remember, moxifloxacin is not anti-pseudomonal. Similarly, your first generation like norfloxacin and naldixic acid and all are not anti-pseudomonal. Only Cipro and levo that we commonly use are anti-pseudomonal. And again, I told you, reserved drug are only two. First reserved drug is your polymyxin DM colistin, which you are going to use it as a reserve only for MDR organisms, and the second reserve drug that you are going to use is aztreonam, which will be used only for ICU patients who are having penicillin allergy. These are also anti-pseudomonal, but these are the drugs that we commonly prefer. But how will you construct a regimen for Pseudomonas? Suppose if you are having a Pseudomonas, I told you for coming-acquired MRSA, very easily you form the regimen. Either use a linezolid or a vancomycin as a first drug and add on a clindamycin to any one of those. Either a clindamycin with linezolid or clindamycin with vancomycin. Very easy to form a regimen. But here forming a regimen is not that easy. I mean, it's little complicated. For example, the first drug, anyone you can prefer. And the second drug, again, anyone you can prefer. So it depends on whether it's a confirmed case of Pseudomonas or an empirical treatment of Pseudomonas. Remember, for empirical therapy for Pseudomonas, empirical treatment for Pseudomonas, just use one first line drug. That's all. So suppose in a community-acquired pneumonia, I want a drug that is going to cover a Pseudomonas. In that condition, I can use just a single anti-Pseudomonal drug, like an anti-Pseudomonal penicillin, cryptazolin, tazobactam, or a co-generic cephalosporin or a carbapenem, suspected case, plus or minus, you are going to add a second cover, plus or minus. Suppose in a definitive case, I have to add one first drug, plus definitely I have to add one second drug, any one of the second drug. So typically in a confirmed case of Pseudomonas, my treatment will be definitely a piperacillin tazobactam with the levofloxacin, or a piperacillin tazobactam with the amikacin, or a meropenem with the levofloxacin, or a meropenem with the amikacin. And one more interesting fact to state is that if you think that Cipro versus Levo, which you think is more effective for Pseudomonas, astonishingly it's the Cipro that is more effective, not the Levo. And again, it has more pulmonary penetration compared to levofloxacin. So I'm going to use ciprofloxacin if at all if it's sensitive. Fine. So this is how you construct a regimen, but it comes automatically most of the time, because here I told you the regimen itself, if it's an ICU patient, means the regimen itself will be a beta-lactam, and I'm going to prefer a respiratory quinolone as an add-on. So if you have a Pseudomonas suspicion, give a beta-lactam, one among the three drugs which I told you first, and add a respiratory quinolone, that's levofloxacin, that's enough. But in this condition, I don't. If it's a Pseudomonal suspicion, then the respiratory quinolone I'll be using will not be moxifloxacin. It will be levofloxacin only, because fourth generation quinolones do not have anti-Pseudomonal cover. So it's all about your calculations and what is your suspicion, and it's all about justification. It's not something called a concrete flowchart is there for all these things. It's about the bug that you are seeing in suspecting and the bug you are seeing in ICU. Depending on that, you are going to tailor your flowchart and tailor your management. That's all. It's not like it's a cutthroat rule. You have to just adjust these algorithms. That's all. Clear? Even though this looks messy and this gives you a lot of idea about how to treat a community-acquired pneumonia. But I didn't tell you the basic fact. When do you suspect an MRSA? When do you suspect an MRSA? Ideally, when you are going to suspect an MRSA in a community, I'm not talking about hospital, community-acquired MRSA. Typically, whenever the patient is having a post-viral pneumonia, after post-influenza pneumonia. Clear? Then, if the patient is an IV drug abuser, then if the patient is having treatment failure with, your routine antibiotics, your regular antibiotics that you have given, the patient is going for a treatment failure. Or if the patient is having pleural-based nodules, this indicates actually sepsis dissemination into pleural-based nodules, which means it's actually an emboli, septic emboli, that's what it means. Very high risk of staph aureus. So if you have pleural-based nodules, or if you are having a cavitatory lung lesion with the Gram stain showing gram-positive organisms, plus Gram stain showing gram-positive organisms, especially Cochrane clusters. Clear? I mean, I think Cochrane clusters is what goes to Staph aureus. So if you have any of these things, then you can suspect about a commutative MRSA. Then you can add vancomycin or linezolid with clindamycin to the existing regime. When you are going to get a pseudomonal suspicion, suppose we have discussed in detail about pseudomonas and how to give a pseudomonal cover. So when do you think it's a pseudomonal suspicion? So number one, patient who is having a structural lung disease. This is the most important thing, structural lung disease. And second thing, in IV drug abuse also, you can think about pseudomonas in this condition also. But remember, the structural lung disease is the most important point. What do you mean by structural lung disease? There are typically best examples for this scenario is a patient who is suffering from bronchiectasis, or if the patient is having a cystic fibrosis. In these conditions, the possibility of having a pseudomonas is very high in the commutative pneumonia. But hospital pneumonia, definitely pseudomonas is a high possibility. But hospital means pseudomonas. MRSA, hospital means MRSA. That is different. Let us see in hospital pneumonia section. Here we are talking only about community acquired pneumonia. We are not talking about hospital pneumonia. Be very, very clear about that. Understood? So, in a commutative pneumonia, structural lung disease is the one that is going to predispose to your pseudomonal colonization and infection. So this is where you are going to suspect a pseudomonas. So let us see some real-time case scenarios. So for example, a 60-year-old male, alcoholic, coming with typical commutative pneumonia. All the findings are there. Clinical features are which was sputum with, a cough with expectoration for very acutely developed high-grade fever, let us assume. And chest X-ray is also very classic of, commutative pneumonia. So what is the treatment you are going to give in this patient? So typically, and I am telling you the CUP65 score is 3 and the patient is not in ICU. So what I am going to prefer? Definitely the score is 3. So first of all, I will think it's as IP. Mostly it will be a short IP and observation. Depending on how he is responding, I will be moving further on. And the antibiotics I am going to add is going to be, since he's having a score of 3, I can either use a respiratory quinolone because it's not IC, non-IC. So beta-lactam is not a must here. So I'll be using a respiratory quinolone, like either a levofloxacin I can give. I can use 750 milligram IV OD levofloxacin, or I can use a beta-lactam plus a macrolide. In this condition, in this patient, typically I will be preferring maybe a ceftriaxone plus azithromycin. Ceftriaxone may be the standard dose of ceftriaxone is 2 gram IV OD for adults and azithromycin 500 milligram, either IV OD or a oral drug. You can use IV or PO, oral. Both are can be used. So this is what I am going to typically prefer if it's a non-ICU patient. Let us assume, now give a second clinical scenario, a 72-year-old male who's having a CUP65. Again, typical features of a commutative pneumonia, all these features are there, it's not hospital acquired, and is having a CUP65 of 5, and chest X-ray also shows extensive bronchiectasis. Then later on through history, you understood it's a known case of bronchiectasis for a long time because of maybe a TBC equally, you don't know that. So chest X-ray is showing extensive bronchiectasis, and CT is confirming the fact that he's having severe bronchiectasis. And since the score is 5, he's in ICU now. And what you are going to do for this patient? Clear, there are two things that you have to know. One, it's an ICU patient, and second thing, he's having a high risk of pseudomonas. So what I'm going to do is, I'm going to use a beta-lactam for sure. At the same time, I'm going to use a respiratory quinolone or a macrolide, anyone, respiratory quinolone or a macrolide. Here, the beta-lactam I'm going to prefer must be anti-pseudomonal. And among these two, I have to prefer anyone. So here I will be definitely preferring respiratory quinolone because here macrolide doesn't have anti-pseudomonal cover because I have a pseudomonal risk. So that's why I'm preferring anti-pseudomonal beta-lactam. At the same time, I prefer respiratory quinolone instead of macrolide because I need to cover pseudomonas. That's a priority. So respiratory quinolone I'll be preferring is either a second or a third generation respiratory quinolone. I mean second or third generation quinolone. But remember, second generation is not a respiratory quinolone. So I'll be going for a third generation respiratory quinolone, that is levofloxacin. And your anti-pseudomonal drug I'm going to cover is like either a piperazine tazobactam, or I'll be using a meropenem. For example, you can use imipenem or doripenem also, or I can use a cefepime. I mean, theoretically ceftazidime, but cefepime is what I'm going to prefer. Suppose if the question also tells penicillin allergy, I cannot use any of them. If suppose the question also tells you penicillin allergy, I cannot use any of these drugs. Instead, I will be using aztreonam plus levofloxacin. Aztreonam plus levofloxacin. So this will be my regimen that I am going to consider. Very simple. Now let us assume a 43-year-old male again getting a community-acquired pneumonia, typical history, but he had a history of URI or influenza findings like sore throat, myalgia, all these things 1 week ago. 1 week ago. How will you treat this? And I'm telling my curve 65 score is 4. What are you going to do? So first I'm going to treat like an IP. If I'm going to treat like an IP, what IV antibiotics I'll prefer. So now I'll be using a regime that should contain the commonly used community-acquired organisms also. At the same time, I should cover MRSA also, because since he had a post-influenza pneumonia, there is a high risk of MRSA, so I have to give an MRSA cover. And this MRSA must be community-acquired because he is suffering from a community-acquired pneumonia. CAP. So what is the regime I am going to use? So since he is an IP, not ICU, I will be using a respiratory quinolone like levofloxacin. First, I am going to construct this regime, or I can use a beta-lactam plus a macrolide. Beta-lactam plus a macrolide. Remember, none of the beta-lactams are effective for MRSA. So beta-lactam I am going to use is like it could be IP, so I can use a ceftriaxone or a cefotaxime here. So or a cefeprazone sulbactam. So let us prefer ceftriaxone here. And a macrolide I am going to prefer is a azithromycin. So I am going to use this combination or levofloxacin alone, but along with this regime, so I am using any one of this regime, either levofloxacin or a beta-lactam plus macrolide. At the same time, I have to give plus clindamycin plus vancomycin or linezolid. Depending on like renal status, you can do. So then vancomycin is nephrotoxic drug, the patient is okay, not so sick, or having normal renal parameters, you can go for vancomycin also. But in generally, vancomycin is reserved for ICU patients. If you are treating as an inpatient but non-ICU, you can prefer linezolid also. So that's like less nephrotoxic, but it's a bacteriostatic drug. But vancomycin is the gold standard for any MRSA. It is the bactericidal drug. Like it's the gold standard. Linezolid is going to be bacteriostatic, and we don't really prefer linezolid if the patient is really sick and having normal renal parameters. Very sick, normal renal parameters, always go for vancomycin as the important therapy. Suppose if the same patient, I'm telling you, if he's in ICU, what are you going to do? Same patient, if he's in ICU, I'll be using a beta-lactam. Typically, I'll be using a piperazine tazobactam, let us tell you, it's a beta-lactam. Plus, I'm going to give a respiratory quinolone or a macrolide, let us assume it's a levofloxacin. Plus, I have to add a clindamycin. Plus, I have to add a vancomycin if there is a MRSA suspicion. Clear? So remember, ICU patients, beta-lactam is a must. So this is how you construct a regime. Again, constructing a regime depends on your personal expertise, as well as the algorithms are just to help you. But again, you are the one who is going to construct the regime and what is proper for the patient, what is the suspicion, what is seen in your community, and that is what you are going to use it. Fine. So this is how you construct the regime, and these are the empirical regimens for your community-acquired pneumonia. But one fact I didn't tell you in community-acquired pneumonia is that why did you use this macrolide, doxycycline, quinolone in almost all the regimes? In all the regimes, you are using either quinolone or a macrolide or a doxy. in all the regimes. This macrolide, quinolone or doxy comes, but in IC doxy will not come. But why in every single regime you have a macrolide, or you will be having what? A doxy if it's a non-ICU patient, or at least you are having a respiratory quinolone. In all the regimes, in every single regime you have this, any one of these drugs. Why? Because these drugs are added in a cap regime to cover atypical organisms. That is the reason why you add any one of these drugs in all the three regimes, because these are very important. These are atypical drugs, like for example, the four most important atypical organisms. Let us see the organisms first. The four most important atypical organisms are your Mycoplasma, Legionella, Chlamydia, and Rickettsia. And four important atypical drugs are there. Only these four drugs cover atypical organisms. These are intracellular organisms. That's the problem. So atypical four most important drugs. One is your macrolide group of drugs. Second, quinolones, especially levofloxacin. Then chlamydia, and you have the tetracyclines, especially doxy, and here chloramphenicol. But chloramphenicol, why I am writing separately like this is because it is currently not used very commonly because of its toxicity. Like idiosyncratic effects like bone marrow suppression are very high with chloramphenicol. That's the reason why we don't prefer this drug, even though in very resistant MDR, typhoid cases, not still we use this chloramphenicol. But anyway, that's ID part, that's not your job right now. Anyway, these are the three most important atypical curves that you will get. That is the reason why to cover these organisms only you are adding this macrolides, levofloxacin, or doxycycline in almost all the region. And if you ask me what is the treatment for Mycoplasma, it must be macrolide only. Typically, I am going to use azithromycin. That's actually the best treatment. If you ask me the best treatment for Legionella, it is levofloxacin. You can remember L for Legionella and L for levofloxacin, M for Mycoplasma, M for macrolides. And for chlamydia and rickettsia, obviously the treatment will be doxycycline. Clear? So that is the reason to cover atypical organisms only we are adding one of these drugs. In that, like your macrolides and quinolones have a little bit of gram-positive and gram-negative cover also. But typically these drugs are added in these circumstances to cover the atypical organisms only in a cap setting. Fine. So now we have discussed in detail about all the treatment of community-acquired pneumonia. With this, we can finish off with certain important aspects of community-acquired pneumonia, but which means sometimes the community-acquired pneumonia may need a chest drain. And definitely they will be asking you what are the indications of chest drain in a community-acquired pneumonia. The only one indication, if you ask me, is complicated parapneumonic effusion. This is almost the only indication as far as you know, but we have another rare indications like if you aspirate frank pus. Frank pus means actually they have gone for empyema. That's what it means. Aspirate a frank pus during thoracosynthesis. Number 3, if you have a high risk pleural anatomy in CT, this only can be depicted through CT. High risk pleural anatomy. Frank pus is known as empyema. Fine, whenever the pleural space is having a frank pus, it's empyema alright. So there you have to drain, because if you don't drain, I'll tell you what will be the side effect, because you're not going to reduce the fever and the patient will be symptomatic only continuously. You have to drain this. That is the reason these 3 are indications for chest drain. In that, what do you mean by a parapneumonic effusion? Parapneumonic effusion is a reactive effusion where you form a pleural effusion like in adjacent surface to the pneumonia. It's a reactive kind of an effusion. But if the organism starts invading the pleural space from the nearby pneumonia consolidation, so that is what we call as a parapneumonic effusion. Remember, what are the evidences that organism is invading the pleural space? Very simply, if you have a pus, definite evidence that organism has already invaded and is present in the pleural space, then only you can form a pus. Or if the organism is invading the pleural space, but if it's getting washed away by the pleural circulation, you might not form an empyema, but you will just have the catalyst of pleural fluid that is resembling a invasion of the bacteria into the pleural space. That is called complicated paranemic effusion. So, what are the features of the pleural fluid that will tell you it's a complicated paranemic effusion? Number one, your pleural fluid pH is less than 7.2. Please note that the pleural fluid pH normally it is 7.6 or above, it is alkaline. If it is less than 7.2, definitely in the presence of pneumonia, it's a complicated paranemic effusion. It's not a simple paranemic, it's a complicated paranemic effusion. If LDH is more than 1000, because the neutrophils are coming there and the cell is growing rapidly there, the inflammatory cell growth, that's why the LDH is very high, more than 1000. Or if your culture is positive and yielding an organism, remember the pleural fluid is one of the very sterile fluids in the body. So it's not at all supposed to have any organisms with them. If you have any culture that is showing positivity in the pleural fluid, that's also an equivalent to your complicated paranemic effusion. Or if your gram stain shows some organism. I'm not saying gram stain positive because you might mistake it for gram positive organism. So gram stain yields some organism in the pleural fluid. Again, this is definitely your complicated paranemic effusion. But remember, if they ask you in a complicated paranemic effusion, most commonly the cultures will be negative. Most commonly, and even sometimes culture may be positive, but very commonly your cultures tends to be negative in a complicated paranemic effusion. You might ask me, sir, how is this possible? The organism is invading the pleural space, which means culture should be positive. Not like that. Organisms, even though they are invading, they are rapidly cleared by the circulation of the pleural fluid. So very commonly they will be culture negative. But empyema usually yields a positive culture. There is no doubt, because you see the pus, which means there are organisms over there. It definitely is. High risk pleural anatomy is CT scan. So what are high risk pleural anatomy? If you have loculated effusions, it's definitely a high risk pleural anatomy for future empyema. That's why. And if you have a thickened parietal pleura, even if you don't get a frank pus, this thickening of the parietal pleura usually indicates an empyema. And this results in something called a split pleura sign, which you'll see in subsequent section when we are discussing about empyema. But this thickened parietal pleura is again a very important high risk anatomy. And in very large collections, very large fluid collections in the pleural space, like especially if it's spanning more than half of the hemithorax or more than 50% of the hemithorax, if it spans big collections, definitely it has to be drained. So these are the typical indications for inserting a chest drain in a paranpneumonic effusion. But very importantly, this is what they will ask. This complicated paranpneumonic effusion is what they are going to ask in exam. Empyema, definitely everyone knows. It has to be drained. Remember, if you don't drain this complicated paranpneumonic effusion or empyema, the patient will not respond to antibiotics. It means he will continuously have fever and he will have the cough. He will look sick. Clinical improvement will not be there. So that's very important. So if you drain the fluid only, they will improve. Fine. Now, what are the causes of poor response to your antibiotic therapy? Poor response to antibiotic therapy. First one is wrong diagnosis, which means you might be dealing with a cancer. It could be a bronchoalveolar cancer. So always, if you have not done a CT, do a CT as a next step if you are not responding to antibiotics. Clear? Wrong diagnosis. Second, it could be a wrong organism, which means you are encountering a virus probably, or any atypical organism which you are not giving adequate cover. In the current era, it generally give atypical cover in all cap because the guidelines are very strong. But in general, virus is the usual reason for wrong organism. So you are targeting a wrong organism, maybe. Number 3, if you are having a complicated paranpneumonic effusion, or empyema, or high-risk pleural anatomy. So this definitely needs chest drain. You have to put the chest drain and remove the fluid, then only they will respond. For this, you have to do a CT. For this, you have to tailor your therapy accordingly, depending on, because many of the viruses cannot be treated, but certain viruses, if you can treat, you can treat them. So it depends on what virus it is. So anyway, so these are the causes for poor response to your therapy, your antibiotic treatment. So the next thing, final, is the complications of commutative pneumonia. Number 1, it's paranpneumonic effusion. If they ask me the mechanism of paranpneumonic effusion, it's fibrinous pleuritis. Fibrinous pleuritis, that is the mechanism of paranpneumonic effusion. Then empyema is a complication, sepsis, definite complication, lung abscess, this is usually common in aspiration and immunosuppressed patients, but not in real time, lung abscess, or they can even go for respiratory failure and ARDS. We have seen one of the important causes, and in fact the most common pulmonary direct cause of ARDS is pneumonia. So they can go for respiratory failure and ARDS. So these tends to be the complications of community acquired pneumonia. Clear with this, I think we have dealt on community acquired pneumonia in a very extensive fashion. I have literally told about almost all the points that you need to know about the community acquired pneumonium. So cheers, and we move on to the next topic.